What's up? What's going on, guys? It's a pretty good song. I don't have to close down the PowerPoint. I don't know what it's called, but I like it. How you guys been today? Good? I'm gonna leave this on a little. Hold up. Oh, come on. My remote's not working. All right, there we go. You guys enjoy Case of the Day today? Man, first of all, hold up. It's Friday. So first of all, are you enjoying Friday? You guys like all out of work by now? Unless you're on the Shazam it. Yeah, why don't you Shazam it right now, actually? I'll turn it up right now. You do it. Got my phone running. Got the laptop running. It's been a great day. There you go. Yeah, it was a crazy busy day again today. We had a lot of really good cases that came through. I was reading abdominal imaging today. Lots of MRI. We are really heavy on MRI, so we do a lot of it. So it's a really good practice, a lot of MR. CTs are always coming through all day long. So we had really good cases, a lot of metastatic follow-up. What else? Anybody know what May Thurner is? It's been a case that we've been kind of dealing with all week. Combination with IR and diagnostics. We can go over that sometime. Let's get to case of the day. COTD. Not to be confused with COPD. I'll leave you short of breath. All right. So here we go. This is the case of the day, right? This is what I posted. Now, man, let me turn down this music some more. All right. Let's start from the very beginning. I didn't give you a history. You don't need a history for this. This is, once you see this once you know what it is, you will not forget it after that, all right? So let's break it down. Yep, there you go. Somebody's already answering it. Sean, he's got that going on, right? Let's break it down, though, from the very beginning, like I'd like to do. So let's, first of all, what modality is this? What are we looking at? Is this an X-ray? Is this an ultrasound? CT scan, MRI? Yeah, some of you guys may be like, man, why are you asking that? That's too easy of a question. But hey, everybody's on a different path, right? Everybody knows more or less than the other person. So what's my general rule of thumb is look at these guys. You see the vertebral bodies. If they're super, super white, it's a CT scan. If they're darker or completely black, it's an MRI. General rule of thumb, remember that, all right? So we got a CT scan. Now we have to ask ourselves, is this contrast enhanced or not? And how do you know it is with contrast? Okay, some people can say, well, look at the vessels. The vessels are opacified. Sure, I get it. What if you can't really tell with the vessels? Sometimes when patients are too obese, it's not really easy to see with the vessels. What other things can you look for? All right, Sean answered again, look at the kidneys. But what specifically about the kidneys? Yes, the kidneys are bright, but what specifically about them makes you know that this is a contrast opacified exam? And specifically, there's different phases of contrast that we can get. You can get an arterial phase, a venous phase, a portal venous phase, and then even a delayed image or a urogram, basically, where you're opacifying the renal collecting system. So what I want you guys to look at is, look, bam, there you go. You got it, corticomedullary differentiation. So look at the darker area in between the medulla, look at the brighter area on the periphery, the cortex, corticomedullary, and it's a differentiation. So you have corticomedullary differentiation. That's how you know it's a contrast opacified exam. Now you have to figure out, all right, well, is this an axial cut? Is this a coronal cut or a sagittal cut? I love doing this. Axial this way, coronal this way, sagittal this way. So going back here, which way is this? This is coronal. So this is how you're going to answer every one of these questions if you're in case conference, if you're a radiology resident. I would start off by saying, well, I have a coronal cut, a contrast enhanced CT examination. It's at the level kind of posteriorly where the kidneys are. What other organs do we see? We see the liver here. We see kidney. Anybody know what these are right here? Anyone? They're important. They're really overlooked, honestly, on CT scans, but they're important when you look at like KUBs. They can become important. But these are the psoas muscles, all right? And then I mentioned the liver. I did not yet, but here we go. Here's a little bit of bowel and some bowel over here. And then what is this big old Goomba? What's going on here? Somebody already mentioned it before, right? Where's the spleen? Does anybody see the spleen? Tell me when to stop. Maybe a little bit here. I don't know. Maybe. I don't know. Maybe a little bit here. I don't know. Maybe a little bit here. Bottom line is the spleen's everywhere. All right. So this is a basically splenic rupture. There's different gradings of splenic lacerations. You can just easily go look them up right now, Google it, and it's going to go grade through 5, basically. And this is a 5. This thing is, completely burst open. So the spleen, just because you don't see it, you know it's all fragmented, you know it's a splenic rupture, but you need to take it one step further. You need to go and evaluate this scan even more than just that. I need you to now look at density differences, right? Because that's what CT is all about. I need you to check out the density here. I need you to check out the density here, here, and here. Do you notice how, right, there's a grading system. It's darker, it's a little bit brighter, and this is bright, right? And go back on my stories if it doesn't project nicely on the screen, but go back on my stories and notice how bright this is, all right? And here we go. Let's go to the axial version of it, right? Look at how bright this is right here compared to this and compared to this. So what are the 3 different densities that I'm pointing out right now? Well, 1 we said is the spleen. Number 2, this is actual blood, okay? So this is hemo, blood, and peritoneum inside the peritoneal cavity. So this is hemoperitoneum, all right? And this is active extravasation of contrast, meaning, aka, that there is blood literally spurting out of a vessel into the abdominal cavity. This is extremely important. This is a flagrant example of it, right? If you can recognize now what active extravasation is, what it means, and why it's important, then it will help you down the line when you're looking at subtle cases of active extravasation. So again, this is flagrant active extravasation, meaning this patient is going to bleed out into their abdomen pretty quick. All right, so they're going to need rapid transfusion, fluids, fluid resuscitation. They're going to need blood products, get some central lines in there, 2 large bore 18 gauge IVs, whatever is, somebody's capable of putting in at that time. And this is going to need to be dealt with, okay? So some splenic lacerations, people, fall from a balcony, people are in car accidents, they get punched, whatever it is, and you may just see like a little line going through the spleen. There may be a little bit of blood products around the spleen, aka perisplenic blood products, and you just kind of monitor them. You're like, all right, the patient's not really hypotensive, the patient's not tachycardic, I'm not too worried about it. Why does I always mention this, by the way, when I talk about these patients who are septic, in shock, or like, somebody's bleeding out right now. If anybody is confused why I always say this, but remember, hypotensive, tachycardic, that's the body's response when they become hypotensive. Basically, the blood vessels, maybe the blood vessels are way too wide open. Their arteries are way too wide open because of some sort of septic response. So whatever's causing the vasodilation, when the vessels dilate, the end arterial pressure is going to be all messed up and the blood pressure is going to tank, right? So the body's natural response is to be like, whoa, hold up, my end organs are not really getting perfused that well. Let me crank up the heart rate. So hypotensive, tachycardic, that's what you're looking for when you're looking for an unstable patient, and they may require whatever intervention is causing the problem. Say if it's blood products, because if somebody's bleeding out, well then hurry up and get those blood products in, right? That's aka hemorrhagic shock. So I need you to recognize that not only was this a splenic rupture, complete grade 5, I want you to know that there's hemoperitoneum in there as well, and I want you to know what active extravasation means. Now, active extravasation, if it's small and if it's like, maybe oozing into like a piece of bowel, that can be hard to detect, all right? And I mentioned before, phases of contrast on CT. If it's a venous phase CT, well, you know what? An arterial bleed, you probably won't see it. If it's a portal venous phase, you probably won't see it. If it's a delayed, you probably won't see it. If it's an arterial phase CT, yeah, you may see it. So it's very important to know what phase of contrast that you're looking at on the exam to really know, hey, did I really exclude an active bleed? So usually when people do trauma protocols in the country, this is the picture that I'm talking about right here. My case that I put up. This is the active extravasation right here. This bright, bright, bright area. This is hemoperitoneum. This is a little bit of spleen left over. That's what I'm talking about. And here's the axial image of it. I also want you to take note that there's a lot of mass effect on the adjacent structures as well. I think it's nicely laid out here. The kidney's kind of bogging down a little. Things are being pushed that way. So there's a lot of mass effect caused by this hemoperitoneum. All right? Those are the main things. What else do I want to tell you about this? I don't know. I think that's pretty good for this. Any questions? Who's got questions about this? Who has questions about this? This is a classic trauma case, meaning somebody had a trauma ATV accident. Man, stop writing ATVs. People get into so many ATV accidents, it's not even funny. I see those, and not only do they get in ATV accidents, ATVs has some of the worst traumas I have seen. That and people riding motorcycles without helmets on. Sure, you may look cool with your hair like flowing in the wind, looking like, I don't know, but seriously, at least put on a helmet. You don't understand how many head injuries come through our department every single day, and the indication is motorcycle accident, no helmet. They're bad. Point out a couple basic landmarks to work off when you first check what's going on. What do you mean by a couple of basic landmarks? Just in general in the abdomen, or are you talking about like a splenic rupture? And snowmobiles, yeah, you can tell I'm from California and I don't really go into on the snow, so I don't think I've ever ridden a snowmobile actually. They look really fun, but I'd be the guy kind of just like going like 2 miles an hour because of the head stuff. I see this every single day, no joke. In general, oh, you're a beginner. I got you. Well, yeah. First of all, if you're a beginner, go look up, start from the very basics. Start with, go on my YouTube, it's on my homepage, or whatever you call that, my whatever page, right? And go in my bio and check, there's my YouTube link there. I suggest going over the chest X-ray lecture, which is for basic chest X-rays. And then I broke down ultrasound. Go to that lecture as well. And I'm going to soon put together a CT abdomen talk. And we're going to go through just everything about the CT abdomen. And we're going to break everything down. We're going to go through my surge pattern. We're going to go through what things are like common, what are not common, pitfalls, all that stuff, just like the chest X-ray lecture. So I suggest doing that if you're a beginner. And I'll get the CT lecture hopefully pretty soon. Any other questions, guys? Can I answer for you? Let's see what song is back on now. I don't know what this is. It's not bad. It's kind of soothing. All right. Should we call it? Yeah. All right. I think I'm about to call it. Oh, you got a question right before I was about to give the deuces. Prognosis for patient? Oh, it's variable. If it's a young patients can really kind of compensate for a lot of stuff. This happened to be a youngish patient, and when the spleen is completely ruptured like this, it's basically they're going to surgery right away. They're getting an X-lap and they're taking out the spleen. And if it's like a splenic rupture with a little bit of active extravasation, something like that, they'll consult us in IR and we can go in and endovascularly kind of plug up the bleed, whether it's with coils or with gel foam, anything. So it's variable prognosis for the patient. All right, guys, that's it. I'm out of here. I appreciate you, and we'll pick it up again. Later.